to my presentation. The topic covered in today's presentation is rhabdomyolysis. My name is Caitlin Emery, currently taking Introduction into Human Anatomy and Physiology with Professor Yube. During the presentation, I will introduce rhabdomyolysis, discuss background information, causes, symptoms, treatment options, and how to prevent rhabdomyolysis. Rhabdomyolysis has an interesting background. The earliest appearance is said to be in the Old Testament, Book of Numbers. It is recorded that during the Exodus from Egypt, the Jewish suffered a plague with signs and symptoms of myolysis, or the breakdown of muscle tissue. The plague is hypothesized to have resulted from significant consumption of quail during the Exodus, as quail ingest poisonous hemlock during their spring migration. The first medical description of rhabdomyolysis is in the German medical literature from the early 1900s, which was known as Meyer-Betz disease. Bywaters and Beale are often acknowledged for providing the earliest explanation of the pathophysiological mechanism behind the condition, as well as accurately describing the link between rhabdomyolysis and acute renal failure. As noted by Rawson et al., rhabdomyolysis was originally referred to as crush syndrome and was first identified in the 1940s during the London Blitz, when patients' limbs were crushed. Although the majority of patients survived their initial injuries, many died due to renal failure in the following days. Recognizing the signs of rhabdomyolysis is crucial, as its clinical presentations range from asymptomatic elevations in creatine kinase levels to potentially life-threatening complications. Accurate diagnosis of rhabdomyolysis enables timely management and intervention, thereby reducing the risk of additional harm. Rhabdomyolysis is necrosis, or the breakdown of skeletal muscle tissue, causing the release of fiber contents into the bloodstream and urine. Regardless of the underlying cause, the progression of rhabdomyolysis follows a consistent pattern. Direct myocyte injury or failure of the energy supply within muscle cells result in rhabdomyolysis. Normally, while at rest, ion channels in the muscle cell membrane maintain low levels of sodium ions and calcium ions, and high potassium ions inside the fiber. Depolarization triggers calcium ion release from the cytoplasmic reticulum, leading to contractions via actin-myosin interaction. These processes require ATP. Damage to ion channels or reduced ATP disrupts electrolyte balance in muscle cells. Disruption of calcium homeostasis resulting from changes in intercellular sodium levels can activate proteases and phospholipases. This process results in the breakdown of proteins that make up the contractile apparatus, cell membrane, and cytoskeleton. As a result of myocyte breakdown, substantial amounts of intercellular components, especially potassium, myoglobin, and creatine kinase, are released into the bloodstream. Cabral et al. Report that when skeletal muscle injury involves more than 100 grams, circulating myoglobin levels surpass the plasma's protein binding capacity, resulting in precipitation within the glomerular filtrate or nephrotoxic, resulting in acute renal failure. There are multiple causes of rhabdomyolysis, to include acquired and genetic. Acquired can be broken down into three groups: trauma causes, exertional non-traumatic causes, and non-exertional non-traumatic causes. The genetic group includes genetic disorders. Trauma-induced rhabdomyolysis includes crush injuries following natural disasters or man-made events, for example, bombings, earthquakes, or building collapses. Vehicle accidents, compression of blood vessels as seen with the application of a tourniquet, high voltage electrical injury, vascular or orthopedic surgery. Exertional non-traumatic, also known as exertion rhabdomyolysis, includes strenuous muscular activity, seizures, sickle cell trait, exposure to extreme heat, most commonly seen in heat stroke, hypokalemia, and neuroleptic malignant syndrome, which is a reaction to antipsychotic agents. Non-exertional, non-traumatic causes encompass substance abuse, such as alcohol, opiates, LSD, and ecstasy. Toxic agents, for instance, carbon monoxide and herbicides. Infections that include influenza, virus A, and HIV. And lastly, electrolyte imbalances. Lastly, genetic disorders include enzyme deficiency and myopathies, resulting in insufficient delivery of ATP. In addition to disorders of glycolysis or glycogenolysis, disorders of lipid metabolism, muscular dystrophies, and other genetic conditions can lead to rhabdomyolysis. Clinical presentations of rhabdomyolysis vary due to the extent and severity of muscle damage. However, the most common triad of symptoms are muscle pain, weakness, and dark-colored urine. Dark-colored urine is seen as brown, red, tea, or cola-colored. This is due to the kidneys filtering myoglobin from the blood, which spills into the urine. Additional clinical presentations consist of abdominal cramping, muscle swelling, muscle stiffness, discoloration, or blistering of the skin. Systemic presentations include malaise, such as feelings of discomfort or uneasiness, fever, nausea, and vomiting. Patients may become confused, agitated, or delirious in the most severe cases. Rhabdomyolysis can occur in all age groups and all genders. However, the disease appears more frequently in males. It is estimated there are about 26,000 cases of rhabdomyolysis per year in the United States. Interestingly, 80% of rhabdomyolysis cases found in adults result from contact with toxic agents such as alcohol and medications. Exertional rhabdomyolysis accounts for approximately 4 to 33% of all rhabdomyolysis cases. No matter the etiology, the most important goal in rhabdomyolysis treatment is to avoid acute kidney injury and address the cause to mitigate the release of myoglobin. The first and most important step in treatment is rehydration. Intravenous fluids should be administered as soon as possible, ideally within the first 6 hours of muscle injury. For the first 24 hours, enough fluids should be administered to maintain a urine output of about 300 milliliters per hour. Fluids may include bicarbonate to alkalize the urine to help dilute myoglobin or other potential nephrotoxic substances. With severe cases, dialysis may be needed to aid in the recovery of the kidneys. Interestingly, patients with rhabdomyolysis related to mitochondrial myopathy could find low-intensity physical activity to be beneficial by helping the regeneration of normal muscle cells. Although rhabdomyolysis is a rare condition, it is very serious and can be life-threatening if not recognized, treated immediately and properly. Some causes of rhabdomyolysis are unpreventable, for instance, natural disasters or certain genetic disorders. However, some causes, such as substance abuse, can be limited or avoided. Regarding exertional rhabdomyolysis, specifically strenuous exercise, understanding the body's thresholds, working within those limits, and not passing them can help avoid rhabdomyolysis. In addition, ensuring the body stays properly hydrated and electrolyte levels are balanced will not only lead to a healthy lifestyle, but also avoid the risk of rhabdomyolysis. Thank you for taking the time to listen to my presentation. I hope you find the topic presented informative and interesting.